Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Let's go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
I heard you briefly mention fentanyl patches. Do you reach for these often or just in the event of numerous extractions? Good question, Marissa. Again, this is for those patients that we've done multiple extractions and that are in that moderate to severe pain category. And so multiple extractions certainly are in that moderate pain category. So we're definitely going to place a fentanyl patch for a number of reasons. Number one, that is continuous pain analgesia for 5 days. It is one less medication that the owner has to deal with, where they have to administer something. It's just on there. They just have to have it removed. That's all they have to do with it. So it's very, very easy, and it avoids anything doing in the oral cavity. I'm very cognizant of that. I need to make post-op pain meds as easy for the owner as possible. So we try and do liquid that we can mix in with the food, or a chewable tablet that we can crush and put in the food. Something that's easy and that the owners don't have to fight with, that if we can avoid them putting something directly in the mouth, especially following oral surgery, because the owners are anxious about that. They don't want to do anything in the mouth. And I would prefer that they didn't, especially if they're sutures. So let's just mix this in with the food. Chicken or turkey baby food works really well. A little cream cheese works really well. And so we want to make sure that we want to have a really nice protocol that's easy and effective for these patients, so that it's pleasant and we get much better client compliance for following visits. What are your pain medications of choice to send home with a patient multiple extractions? Typically fentanyl and an NSAID of some type, whether it be Medicam or Rimadyl, based on the owner's history, the patient's history and or size. If we have something that is extremely painful, like full mouth extractions, we'll go with gabapentin and we'll add that to it. But typically with a standard periodontal patient that's getting multiple extractions, we'll do a narcotic like fentanyl and an NSAID. Those two together have a really nice synergistic effect. So for sure, we're going to want to send home those two drug classifications. If I have a patient that, for instance, has maybe liver issues and an NSAID isn't the best choice, we'll go with gabapentin. What is your opinion about post-dental antibiotics? We rarely send patients home with antibiotics unless there's an active abscess, and that is the correct protocol. We don't do a lot of post-op antibiotics. It's been found that antibiotics have been way overused, and a lot of resistant strains of bacteria have become a concern. And so if we have a periodontal patient with active odor, pus, nastiness in the mouth, we're going to do an intra-op injection of, in most cases, ampicillin. When the extractions and the oral surgery is performed, Dr. Beckman is debriding and cleaning out a lot of that infected tissue and bone. and closing with healthy tissue. And so if there's any lingering bacteria, the immune system will take care of it. The oral cavity has a tremendous blood supply. It's very, very vascular. So there's a lot of exchange going on. So antibiotics really, really aren't warranted unless you've got an immune-compromised patient, a patient that is, for instance, FIV positive, or a patient that maybe just completed chemotherapy. So those immune-compromised patients, where we can't rely on the immune system, we're going to help those guys out with antibiotics. But for the normal patient, we're not going to do antibiotics other than that intra-op injection. And that's only if we see active infection, advanced periodontal, not for those standard extractions, not for closed root planing. Antibiotics aren't warranted in those cases. So just, an extraction isn't automatic antibiotics. It's got to be active infection going on. What is your typical post-dental extraction pain management? We talked about that a little bit and said, and narcotic. Good. How many days? Again, 5 days post-op is typically what we will do with our post-surgery patients. Again, most patients, the 3 days is the most intense pain after any oral surgery. It drops off significantly after that. And I've had oral surgery myself. I've had a tooth extracted. And that's typically what most folks encounter. And so we'll do 3 days or 5 days of post-op pain meds just to cover. We'll go out a couple extra days, but they typically don't need any longer than that. Very nice. All right. So also had some good questions regarding charting. And charting is another component to putting these cases together and having an accurate assessment and an accurate record of that assessment so that we can track these patients effectively and establish correct timelines and make sure that we're going in the right direction from visit to visit and tweaking things if we need to so that we can still keep in mind the goal here is to stall or slow down that progression of periodontal disease, which is nothing more than just a tissue-eating process. So we want to make sure that we're tracking things correctly. All right, so let's look at our first question here. The Chartific software is what we use. It is software, it's an app that Dr. Beckman developed that works in conjunction with PDF Expert. And you can download right onto your iPad or tablet and get it all set up with your logo and all of that. And then it is a really nice charting system that's easy to do, has fillable fields, and just helps you generate a really nice report. So that's at chartific.com, and so look for that. All right, some other questions here regarding charting. You mentioned that you keep your patient on their back when cleaning. Do I use a trough? How do I maintain them? We typically just use rolled up towels just to kind of keep them in that sternal position, and I'll show a video here in a second. When doing your charting, cleaning, and polishing, do you always stay on dorsal? I do. It helps with, you get much better shot of that oral cavity, and they're pretty flexible. They're pretty easy to put in, lateral, just turning their head without having to reposition their whole body. Julie asks, why do you have a preference to doing the radiographs, charting, and cleaning dorsally instead of laterally? Because of logistics, it's easier, and I've got a video here that will show that. So we'll get this started, and you can see all of that. So we've got this patient on his back, and we're going to complete the prophylactic cleaning, scaling, polishing. And I do this because you just get so much better visualization, as you'll see in this video. And as you can see, I'm holding this ultrasonic scaler in such a way that I can hold it like a pen and then have a balance point. And this is kind of an odd picture, but this kind of illustrates the kind of movement that we need to do those very precise, small movements with our hand to have better control of that handpiece. So I'm going to apply this to my patient. I've got a balance point, and then I'm using a perio tip here, and actually at a bit of a 45-degree angle. It's not straight on the tooth. It's kind of slanted, as the side part of the tip is what's most active to remove that calculus and tartar. And this is a perio tip I can use on the crown as well as subgingivally. And then I can get really good visualization on the lingual aspect of these teeth without having to flip this dog from side to side. So I can clean all surfaces, polish all surfaces with the patient in this position. And I can still tilt their head in most cases and let the water kind of drain out so it doesn't pool in the back of their throat, although we are going to clean out that throat on recovery, so I don't worry about that too much. That's just our standard protocol. Again, here you can see really good visualization, especially in the caudal part of the mandible and maxilla, with them on their back and their head just kind of slightly tilted from side to side. They are pretty flexible when they're on their back. And we just use a towel kind of next to their shoulder as opposed to a V-trough, although you could use a V-trough if you want, but sometimes it's harder to get these heavier dogs into that V-trough on top of a table, and it's just, we just tend to use rolled up towels, but certainly that's an option for that. So now we're on to the polishing portion of this, and you can see I've got my little polishing cup, and again I'm holding that handpiece the same way with a balance point and then holding it somewhat like a pen for very small accurate movements. And when I use this handpiece, just like they do at your dentist, it's not kind of a rubbing coloring like we do with the ultrasonic scaler, but it's more of a touch and lift kind of motion. And we want to apply enough pressure that that prophy cup or prophy angle flares when it touches the surface of the tooth, as you see here. So it's just kind of a touch and lift, and then we're going to make sure that we're going to have that prophy cup filled with paste. So I typically, on a dog this size, would have that into the prophy paste every time I went to a new tooth. And that's essentially what the polishing portion of this looks like. When the patient is on their back and you are cleaning, how are you preventing or minimizing chance of aspiration? Again, another good question. And certainly you can put gauze at the back of the throat, but that gauze does get saturated very, very quickly because we're using, a lot of water, obviously. So we've established a protocol for all of our patients to make sure that we're cleaning out the back of that throat, around and in the trachea. So let's take a look at this video here.
One thing that we always do in our patients after any dentistry procedure is make sure that the airway is clear around that endotracheal tube and in the caudal oral pharynx. So what we're doing now is positioning this patient in order to visualize that. Ideally, you have the person that is holding the maxilla, the person that is holding the endotracheal tube and the tongue and using the cotton tip applicators, and then you have someone else that is giving that person the cotton tip applicators, either one or two, depending on where you're at in the oral cavity. So this is absolutely critical. Clear around the trachea, clear in the trachea if there's any debris there as well, and you can ensure that there's a free airway upon recovery.
What are the big differences for the two different ultrasonic scaler heads? The beaver tail, which is the wider one, is used on the crown only. There is a universal or a perio tip that can be used on the crown as well as subgingivally, and we absolutely recommend ultrasonic scaling subgingivally to get any debris and clean out any pockets as well. So the skinnier one, and it's called either universal or a perio tip. So just check and see what you've got in your practices. How hands-on is the doctor when a new staff member is training to get those first steps? Yeah, absolutely. You want to have the doctor involved if they're comfortable, or if another staff member has been doing this and is comfortable with all of these steps, to be very, very hands-on. Absolutely training and training protocols can be established for every aspect of the hospital, but we typically had a 90-day kind of step-by-step when we're learning new tasks to train the task, have the person do the task, and then have the person demonstrate that they're proficient in that task. And so just kind of lining out and establishing specific steps to getting folks trained and establishing those timelines. And we would certainly recommend that, because again, these are all new skills, and we want to make sure that we're supporting new staff members in getting them trained appropriately and making sure that we're doing things as safely as possible. Becky asks, how many techs does this process require? In our practice, one tech is taking rads while the other is setting up monitoring equipment. And that's typically how our practice is set up as well. Again, not everyone has that luxury. And so sometimes we're in that dental suite all by ourselves. And it's not uncommon for a lot of practices to function that way. And so every once in a while, I'll find myself solo if my anesthesia tech is otherwise engaged. And so what I'll do is I'll start with placing that pulse oximeter on the patient right away. I'll get my x-rays taken in the maxilla, get them turned dorsal, finish my x-rays, and then immediately place all of the other parameters after they're flipped, just to kind of save a little bit of time and to prevent all those cords from getting tangled. But I want something on that patient immediately, so that pulse ox goes on very, very quickly. And then it just takes a couple minutes for me to take my x-rays, and then I'm placing the other leads on and then proceeding from there. It is a little bit of a delay, but we've got to make sure that we're monitoring these patients effectively. Katie asks, because you create an estimate based on extractions, do you have some sort of formula? And this is a big sticking point for a lot of practices in making estimates. And we'll go over this very briefly because we're running over time a little bit here. But we want to make sure that we are itemizing pretty much everything so that the owner can see what is involved in not only anesthesia, but in oral surgery. So I have established an oral diagnostic group, and all practice management softwares allow you to make bundles or groups where I just put in one code and it loads with all of the line items that I need for that initial oral diagnostic, including my injectable medications, the anesthesia, all of the anesthesia monitoring parameters by 15-minute increments, IV catheter and fluids. All of those are a line item. Oral surgery needs to be itemized as well, and so I've established an extraction group that includes everything that I would need for an extraction. For instance, I have an extraction pack, additional dental x-rays, nerve blocks, gingival flap, suture, and additional anesthesia. And then all I have to do is add the teeth. And we have to make sure that we're establishing and letting the owners know that it's not just simple extractions, that there's different rooted teeth in the mouth, the status of that tooth. And so when I have my line items, if you look at this next slide, all of these are in codes in my practice management software. So I will have single, double, triple, first mandibular molar, canine, either immobile, partially mobile, and severely mobile. So it'll take some time to set up these codes in your practice management software, But once you get your groups established, once you get all of your appropriate codes in your software, then it's very quick to make these estimates and then ultimately call the owner with that more definitive estimate once you've completed the assessment. So we want to make sure that we're itemizing all of these things because dentistry is expensive. It's a high-end service. It's not for everybody. And so we've got to make sure that there's a standard of care that we're following and that, in veterinary medicine, you get what you pay for. And these are all of the things that we did with your pet today. That's why it was this total. So we like to show value for all of those services that we've provided. Well, I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.